Okay, this lecture is on hemodynamics. This is usually a very fun and very popular lecture. We're going to put you through a bunch of problems and we're going to talk our way through it. This is not hard stuff. It's only hard if you don't have a method, but I'm going to teach you a method, and you'll be slow at first, but if you follow the rules every time, you're going to be able to figure out some very interesting problems in hemodynamics. So there's 3 rules or 3 steps in hemodynamic analysis, and I've given you a worksheet. And on this worksheet, there's problems we're going to go through. At the bottom, there's pharmacology summaries that you can review about pressors, inotropes, and chronotropes, and vasodilators, and receptors, and so forth. Just so you always have that available because it gets confusing sometimes. There's a lot of other drugs besides these available, but I use this to start with because you can take care of any patient with these drugs, and we can use other drugs as well. But if you just master these drugs to start with, you'll be very comfortable. And you can take care of any patient you want just with these, and then you can branch out. The 3 steps to hemodynamic analysis. And I've written them down for you on this sheet. And don't break the sequence. Everybody wants to jump ahead. First step, calculate the stroke volume. Why do we want to calculate the stroke volume? Because if you just look at cardiac output, if you just look at wedge pressure, if you just look at one number, it'll go up and down from day to day, and you'll think the patient's doing exactly the same. But when you look at things like financial markets and you want to do analysis of companies and businesses, you often look at ratios. Because ratios tell you is how one variable changes relative to another when those variables may be related. And so it really gives you more information. And stroke volume is a ratio of what? What's the formula for cardiac output? Cardiac output equals stroke volume times heart rate. So stroke volume equals cardiac output divided by heart rate. So what you're getting is you're getting flow per heartbeat. And that tends to be a pretty interesting number. And what I do is I'll track stroke volume every day in the unit. You'll come in and one day the cardiac output's 3.7, 4.2, 3.9, 4.7. It doesn't look like it's really changing any. What you don't recognize is it's changing in concert with the heart rate, and you don't pick up that pattern, but the stroke volume will see right through that. A normal stroke volume would be about 70. Cardiac output is, let's say, 5 liters a minute. And a heart rate's 70, 72, that's about 70 cc's per beat. So if the patient comes in, they have a stroke volume of 32, and we do things, and they come in the next day and they have a stroke volume of 36, has the patient changed? Yeah, they've changed. 32 to 36 is a 10% improvement in function overnight. And the next day you come in and it's 40. The next day you come in and it's 44. There are some real significant changes. So how do I know when I want to turn off a balloon pump? How do I know when I want to increase a dose or a drug? How do I know when I want to go from 1 to 1 on the balloon pump to 1 to 2 on the balloon pump? I'll use those stroke volume numbers to help guide me. If I'm dealing with a family and saying, is the patient better? You know, you come in, they're still on the ventilator, they're still on vecuronium, their cardiac output looks about the same, their renal function is the same, and you're tempted to say they're exactly the same, but when you look at this ratio number, you find out, really they're better. And so you can say they're measurably better today. And it really is one of these numbers that's kind of a magic number. So I'm going to make you do stroke volume. And what you're doing when you do the stroke volume is I want you to kind of think of it and ask this question. If the stroke volume is normal, you say, well, this stroke volume is normal, so this is a well-functioning heart. This is a well-performing heart. If the stroke volume is not normal, if the stroke volume is low, let's say it's 30, then you can say, I have an underperforming heart. Now, what you don't know at that moment is, can you make it better? You may not be able to make it better. It may be a permanently impaired heart. So you don't know that you can make it better, but maybe you can make it better. So you can at least say, I have underperformance of my contractility and my function, so what's going on? The second step is you want to assess the preload relationship. Again, a relationship of 2 variables. When our preload talk, we talked about the fact that preload in Starling's curve relates the effect of preload or muscle stretch on performance. So now you're looking at 2 numbers, your wedge pressure and performance number. What can we use to measure performance? You can use stroke volume. You just calculate it. You can use cardiac index. You can use cardiac output. I don't care. Any of those are fine. But you're asking the question, what's my relationship of one to the other? So for instance, I actually draw in these lectures for every case, I actually draw a curve, and this would be the curve we'll draw. And we'll say this is pulmonary wedge pressure, and let's say this is cardiac index, okay? We tend to use cardiac index over cardiac output because it normalizes things for body surface area. So we can compare a football player to a little old lady and not get confused by the number. So cardiac index is a very useful number here. The textbooks will tell you that a patient with a cardiac index of less than 2.2 is in cardiogenic shock. That's probably not really true. We don't hardly ever see people that are above that in our business. So if the number is got a 1 in front of it, you got my attention. 1.9 is not that unusual, but at 1.7, yeah, that's pretty low. But 2.1 is not something that is unusual for us. So just kind of give you a range. What's a low index? When you get down into the 1 point something, you're certainly in the low range. Now, this Starling curve relationship is very interesting because here's what's going on. If you have, remember this from school? We have a blood vessel, and then you have this interstitial space, and over here you have this alveolus. So here's the lung, and here's the blood vessel going through the lung that's carrying the blood either to or from the lung. And here's a little thin space. It's very, very thin, usually only a cell or two thick. That's called the interstitial space. And across that space, oxygen and carbon dioxide goes back and forth, right? And that's how you get blood exchange, oxygen and carbon dioxide exchange in the lungs. What happens is, if the pressure in this blood vessel goes up to a certain amount, and it turns out that pressure tends to be about a wedge pressure of about 20. It can vary a little bit from patient to patient, but just think of it about 20. You start to leak blood or fluid across that barrier. And this interstitial space is kind of like a paper towel, and it starts to get waterlogged, and as it does, it starts to thicken. And we call that interstitial edema. So when you see a chest x-ray report and it says a patient has interstitial edema, that's what it's talking about. You're starting to get boggy in this area between the alveolus and the blood vessel. It's starting to get waterlogged and get thick. What are signs of interstitial edema on a chest x-ray? You may see phrases like ground glass appearance. You may see phrases like curly bee lines. That's really what we're kind of talking about. Now, if the pressure continues to go up, and let's say it gets up to about 25 or greater with your wedge pressure, well, this all gets so waterlogged, it starts to push fluid across into the alveolus, and your airspace actually starts to fill with fluid, and that's pulmonary edema. So these words, I see people use them all the time, and they're not quite sure the distinction. You're going from nothing to interstitial edema to pulmonary edema. And what you're doing is, as you go along this line here, as you go from 10 to 20 to 25, the farther out you go on this curve, the more likely you are to be exposing your patient to the risk of interstitial edema or pulmonary edema. So you have to be thinking about, is that a good thing for my patient or not? So here's how you want to ask this question as you get to step 2. First of all, the first one's just a calculation. It's very simple. It's a mathematical calculation. Step 2 is, what's my relationship of preload to performance? Now there's 3 possible places you could be on this curve, really. What's the optimal wedge pressure? People usually answer the question by saying it's 12. I didn't ask what the normal wedge pressure was. I asked what the optimal wedge pressure was. And the answer is it depends on the patient. And it depends on the state of the patient's ventricle. If you have a normal 18-year-old high school athlete, it's probably 10 or 12. If you have somebody who has a large dilated ventricle, they need more preload because they need to put a little more stretch on that ventricle to try to encourage it to contract more. So they actually tend to do better at a preload of or wedge of 18. So when you hear these stories about what's the optimal wedge pressure, well, the answer is very simple. The optimal wedge pressure is the lowest wedge pressure that gives you the highest performance, which means it's this point on the curve right there. Now, if that number is 4, it's 4. If it's 12, it's 12. If it's 20, it's 20. Everybody's going to be different. And I don't know from any one patient to the next what that's going to be, but that's the optimal place to be. Now, suppose we had a set of hemodynamics and it looked like the patient was underperforming. In other words, their cardiac index was very low. Let's say their cardiac index was 1.2, underperforming. So we would say, well, they're down here somewhere, right? They're down here on this axis. So they're down here. They're underperforming. And let's say their wedge pressure was 4. Well, that's low too. Well, they're right here. Could we do something? Is there some step or action? This is really a volume fluid question. Is there some fluid volume strategy that we could embark upon that would improve the performance of this ventricle without taking a risk of putting them into interstitial edema or pulmonary edema? The answer is yes. We can give them fluid till the wedge comes up to there, to 10, and it should drive them up the curve. So this is a patient you say, yeah, giving fluid would be a smart thing to do. But what if instead they were performing here, 1.9, let's say, and the wedge pressure was 30? Well, they're out here and the curve out here, right? Are you going to improve their performance by increasing their wedge pressure? No. Their performance is all you're going to get. That's as good as it gets for that as far as fluid, as far as stretching the ventricle with preload by putting fluid in the ventricle. You're as good as you're going to get, but you're also in pulmonary edema. So can I get the same performance and get them out of the danger zone from pulmonary edema? If I could pull them from 30 back to 20, wouldn't that be good? And so I want to pull them back there. I'm not going to lose performance. I'm not going to drop because I'm on the flat part of Starling's curve. Pull them back, get them back to there. How would you do that? Diurese them, dialyze them, CHF solutions. I mean, there's all kinds of ideas. Pull the volume off of them. So really step 2 is what's my relationship of volume or preload to performance, and do I have a strategy in my armamentarium to either improve the safety without reducing performance or improving performance by increasing volume? That's all the question you're talking about there. It's a very simple question, which is basically fluids, diuretics, or nothing. You know the old thing about should I give them a fluid challenge or should I diurese them? Well, sometimes you don't know the question. That's where having a swan in really, really helps you. Step 3. Okay, we've talked about a 2-variable calculation, stroke volume. We've talked about a 2-variable evaluation of volume with preload and performance. Now we're going to get a little more tricky, and we're going to go to a 3-variable evaluation analysis of Ohm's law. What does Dr. Ohm say? What's the relationship of pressure, flow, and resistance? And the number we're really focusing on most of the time is pressure. Your job really is to maintain an adequate blood pressure so that you perfuse your kidneys and perfuse your brains and you perfuse your body. Because without pressure, you can't get blood and oxygen to your body. So you're really probably focused on, do I have a pressure problem? And if I do, what's the cause of it? Is it a flow problem or is it a resistance problem? And you got to try to figure that out. If you want to change the pressure, where's your bang for the buck? If you want to really lower it or really want to increase it, where's your bang for the buck? Resistance. So tiebreaker is kind of tending to favor the resistance side of this a little bit, but you don't forget about flow. So we're going to go through each one of these steps, and we're going to talk about what happens with pressure, resistance, and flow. So with your work thing in front of you, let's just talk our way through the first one and look at your worksheet. The first patient on the list, and if you notice on the list I have all of the findings, and then in parentheses in the next line I have what would be considered kind of a normal reading for those. And for instance, right atrial pressure should be about 5, wedge would say be about 12, heart rate between 60 and 100 and so forth. The cardiac output and index I said should be over 4 and over 2 respectively. Let me stop for just a second. How do you calculate a cardiac index? A cardiac index is a measure of unit per body surface area. It's how much you have per meter of body surface area. So you take a number and you divide it by body surface area and you get an index. If you take cardiac output and divide it by body surface area, you get cardiac index. Now most average sized people have a body surface area of about 1.9 to 2, so that's why you kind of see indexes are about half of what the other numbers are. But if you have a big, big, heavy fat person, that number will be really different. So don't forget body surface area. Indexes are really useful. SVR, 800 to 1200. What constitutes a high level of SVR? It's not 1220. SVR is probably not really elevated until it's up over 1500, 1600. Some people get up to 2000, 3000. 2000, 3000, those are really high numbers. 15, 1800, a little bit high. I mean, you don't go crazy about SVRs in terms of, if it's 1219, I got to treat it, it's really, really high. It's not that high. So that's kind of give you an idea about this. So let's look at the first patient. Right atrial pressure is 1. Pulmonary wedge pressure is 4. Heart rate is 100. Blood pressure is 80/40. Mean arterial pressure is 53. Cardiac output 3.0, index 1.6, SVR 1387. Let's go through the steps, and we'll cut the camera for a minute to give you some time to do the calculations. We'll come back on and we'll talk about your numbers in just a second. Okay, we're going to come back to this first case, and we've tried to calculate the stroke volume. What did you get for stroke volume? This is the first case. We always mess this up, so I'm going to make sure we get the calculation right. Any numbers? 0.03. Yeah, 0.03 is what people usually say, and there's a mistake there. What's the normal stroke volume? Over 60. So 0.03 looks like incredibly small, right? What we're doing there, we're missing decimal points. Stroke volume is milliliters per beat. Your cardiac output is in liters, so it's actually not 3, it's 3,000 milliliters divided by heart rate, which is 100. So it's 3,000 divided by 100, so your stroke volume is 30. Okay? Everybody makes that mistake the first time out, so that's why I let you do it, because I want to make sure you get the decimal points right. Okay, let's walk through the steps. Step 1, we calculate stroke volume. The stroke volume is 30. That's low. So we know we have an underperforming ventricle. So this is going to be interesting, because maybe the step 2, maybe the Starling curve is going to help us help the performance of this ventricle. We don't know if it's reversible or not, but we're going to try. So underperforming ventricle. Now let's draw a curve on this patient, and let's draw Starling's curve and try to predict what we think this patient may be. So we'll say this is pulmonary wedge pressure, and this is cardiac index or stroke volume. You can use either one. I don't care which one we use. Let's use stroke volume. What's the wedge pressure in this patient? 4. Wedge pressure is 4. That's probably on the low side, wouldn't we say? We're probably down here somewhere. We don't know exactly on the curve where we are. And what's the stroke volume? That's low as well, right? Cardiac index, that's low. So that's underperforming. So what puts us maybe some down on this curve right here, right? So what would be do we have an opportunity to improve performance by changing preload in this particular patient?
Yes.
How would you want to do that? We're going to give him fluids, right? This is a person that needs fluids. Bang, give him a liter, give him 2 liters, give him plasma, whatever. Let's go to step 3. Pressure equals flow times resistance. So what's the pressure? 80 over 40, so it's down, isn't it? I usually just draw arrows on here just to kind of let me know what's going on. Is my flow down? Yes. And my resistance, where is it? It's on the upper end of normal. So I'm not going to really call it elevated, or if we do, I'm going to put a miniature arrow there. Okay? Now, what should we do about the pressure? You could say, well, let's increase the resistance because we get more bang for our buck with resistance. And you could make the case that that resistance is inappropriately low. Well, it's elevated at 1387. Maybe it should be 1700. But one thing you want to do, if you have time, is you don't want to change 2 things at once, because it starts to really cloud things. Have we already taken a measure that might improve flow? We have, because we just gave him fluids, right? So we just gave him fluids in step 2, so we've already done something that should increase the flow. If we increase the flow, what should happen to the pressure? Should go up. So this is probably all we probably need to do in this patient for step 1 is to give him some fluids. As we give him fluids, based on step 2 in the Starling's curve, cardiac index, flow should go up. As flow goes up, blood pressure should go up. So we've already probably done something to help the blood pressure here. Now, if the blood pressure was 60, I probably wouldn't sit there and wait 30 minutes or an hour. I'd probably go ahead and do something. If the patient's relatively comfortable and their blood pressure is 80 and we find that they look like they're hypovolemic and we're going to give them fluids, I'd probably sit and wait and see how they respond to fluid. They're probably going to do just fine. If you're in trouble, you can add a second step there. You could add a pressor that would increase afterload like dopamine or epinephrine Levophed. You could do that. But I hate to do 2 things at once if you think you've already done something that's going to fix the problem. What kind of patient is this? This is a patient who's been in a car wreck, and they've ruptured their spleen, and they're bleeding internally, and all they need is fluids until they go to surgery and get fixed. This is a volume-depleted patient. This is a soldier shot in combat, or the gunshot wound, or the knife wound, or the ruptured spleen that just needs volume to resuscitate them. Okay? Kind of walk through the process on one patient. Now we're going to walk through the next ones. Okay? Second patient. Radiator pressure of 1, wedge of 4, heart rate of 120, blood pressure 70 over 30. It's pretty low. Mean arterial pressure, I've even done those calculations for you. 43. You know, your kidneys always want a mean arterial blood pressure over 65. That's kind of a magic number. That's what you want to be shooting for. When you have a balloon pump in, you're following mean arterial pressure, 65 is where you want it or greater. So we have a mean arterial pressure of 43. Output is 9, that's high. 4.9 index, that's high. SVR 373. So we'll turn off the camera for a second, we'll pause. When we come back, we'll see what your analysis is. Case number 2. Let's go through the sequence. First step, calculate the stroke volume, 75. This is not an underperforming ventricle. This ventricle is performing very well. That kind of takes us where I don't think step number 2 is going to be terribly important to try to give a lot of fluids to increase performance, because increasing performance isn't really our goal here. Although we do want to look at it, make sure they're not volume overloaded. We don't want to have them in pulmonary edema. Step number 2, what does Starling say about this? Let's draw our curve. So we'll say pulmonary wedge pressure and stroke volume. And what's our wedge pressure? Is 4. And what's our performance? Our performance is very high, so we've got to be up here somewhere, right? And that's a low wedge pressure. So maybe our scale here is 4, 8, 12. But that kind of matches our definition of a good wedge pressure. This is the lowest possible wedge pressure that gives us the highest possible performance. So I don't see there's much to do here in terms of moving up and back on the scope. It's not wrong to give fluids anytime anybody's hypotensive and they're not and have a high wedge pressure. You can make the case, I'd like to give some fluids because they have a low filling pressure and they're hypotensive. I guess I wouldn't argue that. It's not wrong, but it's not going to probably fix much of anything. Okay, so if you put, I'm going to give fluids, I think that's a neutral answer, and I'm not going to give you credit for it. I'm not going to count you off for it. I'm not going to argue about that, but there's no real reason, if we be very strict on our definition of step 2, that fluids are going to make a whole lot of difference in this particular case. I certainly wouldn't do like the first case and give them fluids and let's wait a while and see what happens, because I'm not really doing anything that would particularly change that. So that doesn't help us much. Let's go to step 3 and let's see what Ohm's law says. And if we have pressure equals flow times resistance, and our pressure is low, and our flow is what? High. And our resistance is what? Low or really low? Really low. Okay, I want to increase my pressure. Where's the magic bullet to increase my pressure? Is it increasing flow or increasing resistance? Yeah, I'm not going to get a lot more. I'm probably not going to do a whole lot more. I mean, increasing my flow from 9 liters of cardiac output to 12 is not very likely. This is a resistance problem. I want to give a pressure, right? What pressure would you like to give? Let's look at the list. We could give Levophed. Not wrong answer. But Levophed also has the effect of increasing heart rate and increasing contractility, neither of which I really need right now. So not a wrong answer, but not a great answer. I can give epinephrine, same problem. I give dopamine, same problem. When I give dobutamine, no, that's a flow drug. That's an inotrope. That's not a pressor. So that's not a good drug. Look at phenylephrine, that's a great drug. Neosynephrine in this particular case is a wonderful drug because what does it do? Nothing but pure alpha. No beta 1, no beta 2, nothing but pure alpha. So I like phenylephrine here. What's wrong with this patient clinically? Septic shock. High cardiac output, low SVR. This is an actual patient I saw about 10 years ago. It was about a 25-year-old female. We got consulted. She was up in the ICU. She was intubated. She was in shock. She just delivered a baby a few hours before. And we got called to the bedside to check on her. And what we found was that I'd already given her some fluids. That was okay. Hadn't really helped much. And so I put a swan in her. And I got these numbers. And I said, she's probably in septic shock. So we went ahead and started on IV antibiotics. And I put her on phenylephrine. I got her blood pressure up. I got her kidneys going again. Within about 6 hours, she's extubated, sitting up and talking. And the combination of treating her shock with antibiotics and getting her hemodynamics restored so that we could get things back in line turned her around instantly. I really would have had trouble with that without a swan. I don't think I'd have been comfortable enough to give neosynephrine without a swan in place. So this was an actual case. Let's go to the next patient. Patient number 3. I want you to look at the numbers. We'll turn the camera off for just a moment, and we'll come back and talk about that in a second. Case number 3. I put this on here for a particular reason, because it's going to teach us another lesson. Let's go through the sequence. What's the stroke volume? Stroke volume is 55. Okay, just barely below limits. Not a bad ventricle. Is it underperforming? Well, let's look at some other areas. Cardiac index is 2.6, cardiac output 4.4. I'm not sure I'd really classify this as a significantly underperforming ventricle. So we kind of have a sense that we're doing okay in the ventricles. Let's go to step 2. If we go to step 2 and we look at Starling's curve, what kind of relationship are we finding? Pulmonary wedge pressure, stroke volume. Wedge pressure is 12. And stroke volume is 55. That doesn't look too bad. I'm kind of guessing, if anything, we might be just a little bit low on the curve, but not much. And this is 12. So, you know, should you give someone fluids for a stroke volume of 55? I don't think I would. I think you're in pretty good shape there as far as Starling goes. Don't see a whole lot to do there. That one question was, should we give Lasix? I'd have a hard time making a case for Lasix because they're not in the danger zone with a wedge of 12. And I don't want to drop them down the curve potentially, so I don't think I'd give Lasix. So let's go to the third step, which is pressure equals flow times resistance. And how's the pressure? Pressure is 110/70 with a mean arterial pressure of 83. Boy, I'm happy with that. And how's my flow? I'm happy with that, right? How's my resistance? 1436. I mean, I want to draw a miniature arrow up. I put someone on nipride for minimally elevated SVR, good blood pressure, good flow. You walk away from this and you do nothing. And the reason I bring this up is you don't always have to do something. This is the nurse that calls you in the middle of the night and says, I just shot some numbers, and you know, the SVR is a little high. Should we do something? Patient feel bad? Nope. Patient doing well? Yeah. And urine output okay? Yeah. Lungs sound okay? Yeah. So don't over-treat something. Just because there's this one number that's wrong, don't over-treat it. A real famous board question they always ask in internal medicine boards, they give you a Chem 20, and one thing in the Chem 20 is wrong, is abnormal. They want you to go work it up. And the calcium's a little elevated, and so you go off and do this parathyroid workup, and the answer is don't chase down every mildly abnormal thing, because if you do 20 numbers on a lab test, statistically speaking, one will be out of range. So you don't just go track down everything. And I kind of make this, just because you have the numbers in doesn't mean you have to do anything. So I put this on here to teach restraint. Let's go to the fourth patient. Right atrial pressure 14, wedge pressure 26, so on. We'll turn the camera off. We'll come back in a minute after you get a chance to analyze this, see what you think. Okay, next patient. This patient has a lot of abnormalities. Let's walk our way through it. Stroke volume is 35 cc's. We have an underperforming ventricle. Hopefully we can make it better, no guarantees, but we definitely know it's not doing well. Step number 2, we've done Starling's curve up here. Where do we think we stand on this curve? Where's the wedge pressure? 26. We're out in the pulmonary edema range here. So I don't know where we are exactly, but we're way out here. We're way out here in this curve somewhere, but where are we on the performance indices? 1.9. So maybe 1.9 is somewhere along this curve. It's as good as it's going to get, though, because do we really think that the patient is here on the curve, that they have a low performance, and if we take the wedge from 26 to 40, it's going to get better? No, that's not a safe move, is it? So we really need to take this person from the 26 range, get it back down in the 18 range, and I don't think it's going to make any reduction in performance. I think we're way out on the flat part of the curve, so we're going to give this patient something that reduces preload. You can give people things like morphine, which reduces preload. Nitroglycerin produces preloads. Sometimes they feel better with IV nitroglycerin, but this is really somebody you want to give Lasix to. Lots of Lasix. Interesting thing about Lasix that most people don't know is that if you give a dose of Lasix, your preload drops almost instantly, well before you actually start diuresing. So there's actually some direct effects of preload reduction with Lasix. It's mild, but it's measurable. So this is the kind of patient who comes into the emergency room, and they're sitting up, and they're frothy pink sputum, and they feel like they're drowning, and they look terrible, and you're worried you may have to intubate them quickly. And this is the acute pulmonary edema type of patient. And they just got to get volume off as quick as you can. What did we do as far as Ohm's law, step 3? Is their pressure a problem right now? Not really. Flow down just a touch, resistance up just a touch. But do you really think you need to go after either one of these things right now? No, because the pressure's okay. You just really need to diurese this patient. This is the florid pulmonary edema, I'm drowning type of patient. Get volume off of them as quickly as you can. Okay? Let's go to the next patient. Patient has a right atrial pressure of 4, a wedge pressure of 18. We'll turn the camera off, come back after you get a chance to analyze this patient. This next case is a tricky one, and it's really designed to teach a particular lesson. If you take a bad ventricle, you take a very sick, low ejection fraction ventricle, there are 2 things that will kill a sick ventricle like this quicker than anything else. One is acidosis, and one is high wall stress or high afterload. Those are both killers of left ventricles. So let's look at these numbers. First of all, what's the stroke volume? 28, definitely an underperforming ventricle, so this looks like a bad EF ventricle to me, okay? Can we make this thing better? Let's go ask Starling whether we can improve this any. So we draw our curve, wedge pressure, stroke volume. What's our wedge pressure? 18. And what's our cardiac index? 1.5. We use cardiac index here, 1.5. Okay. Wedge, we are underperforming. Do we really think that we can safely improve performance by increasing volume? Probably not. We'd pay too high a price by going into the interstitial edema or pulmonary edema range. So even though we're underperforming, we probably don't have any good options here in the Starling step 2 curve, do we? So let's go over to the 3rd stage. Pressure equals flow times resistance. How's the pressure? It's okay. Pressure is, mean arterial pressure is 83, so it's okay. How's flow? It's down, isn't it? And how's resistance? It's up, isn't it? Okay. How do we tackle this underperforming ventricle? Now, we have a really dangerous situation here, and it's really important to recognize the danger. It would be easier if you had a chance to examine this patient. This patient would look sick. They would have very cold extremities. They wouldn't feel well. You could just look at them and tell something's not right about this patient. And what's not right is they have a very high wall stress. Their SVR is almost 2200. And we know they've got a bad ventricle, and we can't leave them like that. That's a bad, dangerous situation to be in. Now, what would be the option here? Would be we could go after flow. We can go after resistance. We could go after both. You might meet the case, let's use dobutamine. It's a vasodilating inotrope, but it's more inotrope than vasodilator. So what you're really trying to do there is you're really trying to improve performance by taking this ventricle that's already underperforming and sick with a very high wall stress, and you're going to try to increase the wall stress more by contracting with inotrope. That sounds kind of scary. Not a wrong answer, and it would be used a lot by a lot of people, but maybe not the best answer. The other option would be, what could we do to lower the resistance? Interestingly enough, about these ventricles that are underperforming with very high wall stress, you get that wall stress down, the performance skyrockets. So if you could just make a measure, take an action for this patient that lowered their SVR, what you'd find, if you lowered this patient's SVR from 2200 or so down to 1500, the cardiac index would go from 1.5 to 2.0. Because what you're doing, you're taking all that wall stress off the ventricle, now it can start to perform again. That's a really strong relationship between that. And so it's important to understand these in these bad diseased ventricles. So maybe we'd use nitroprusside. And you do this, you're going to get an argument from the nurse. Because what do we use nitroprusside for? Hypertension emergencies. This patient's blood pressure is only 100 and you're going to give him nipride? Are you an idiot, doctor? No, I'm not. But it's a scary thing. You would never do this without a swan in, maybe even an art line in. But you know what? I've seen people's blood pressure go up on nitroprusside. Why is that? Because you drop the resistance and the performance gets so much better, the blood pressure actually goes up. Because pressure is not resistance. Pressure is flow times resistance. Pressure is not flow. Pressure is flow times resistance. So this is a patient that looks like they're going to die. The nurse knows something's wrong. Something inherently is unstable and wrong with this patient. And we're going to try nitroprusside. And they usually respond very, very well. But you have to be a little careful and concerned about it because of the blood pressure. Now, if the blood pressure is 130, no sweat. Feel very good about it. That's a little tricky. Let's go to the next patient. Got two more. Patient 6 has a right atrial pressure of 3, a wedge pressure of 16. Let's go through the numbers. We'll come back in a minute. Case number 6. What's interesting about this case? Let's see, stroke volume 39, underperforming ventricle. We plot that stroke volume 39 against the wedge pressure in step 2 to look at Starling. And do you want to give any fluids? It is an underperforming ventricle. That's true. Do we think we can safely, treat it? It's kind of hard to give enough fluids so tightly that you can take a wedge from 16 to 18. And I have a hard time believing that much difference is going to really change performance. So I don't think step 2 has much to offer us in this patient. Let's go to step 3. Do we have a pressure problem? Pressure, slow times resistance? We definitely have a pressure problem. This pressure is really low. And what's going on with my performance? Is my performance low? Yeah, it's a little low. 1.9 is not a great number. And where's my SVR? My SVR is 1234. 1234 is not really high. And in fact, for someone who has a blood pressure of 70, that's inappropriately low because your body really should be taking your blood pressure higher than that. We would like to have an SVR higher than that. So how would you treat that? Well, we need to give him some kind of a pressor. We've heard several choices. Phenylephrine, is that the best choice? Well, it would certainly handle the afterload part, but we also have a situation here where we have a low flow state. So if we're going to pick a pressor, we would probably also like to pick a pressor that has chronotropic effects, inotropic effect as well. If we're going to do something, it's one of those situations we really have a chance with one drug to treat both of them in the right direction. We can raise resistance and we can increase flow at the same time. So that puts us into the category of probably using Levophed, epinephrine, dopamine. I probably wouldn't argue with any of those. If we want to pick Levophed or dopamine, I think I'd be perfectly fine. So this is a pressor. We got something going on, get the pressure up. This is a pressure type of case. Fluids don't play a role. Let's go for both inotrope and let's go for resistance. Okay? Last patient, number 7. Right atrial pressure 6, wedge of 16. Let's cut the camera. We'll come back in a minute. Okay, last case. Stroke volume is 40, underperforming ventricle, much like the last ventricle. Let's go to look at the Starling relationship. Wedge is 16, like the last ventricle. Even though it's underperforming, do we really think we can safely move it up the curve? Probably not. Even though we're probably underperforming, we're somewhere down here, I'm not sure we can move it up. We may be here, and I don't think we can safely go up. So I don't think fluid has a lot of role here. What does Ohm's law say? Pressure's okay, but we have an interesting relationship developing here. We've got a low flow state, and we have a high SVR, not dramatically high, not crushing the ventricle high, but I don't want to get into a situation where I take it up so high I start to crush my ventricle. So I've got a couple of things I'm not too happy with here. If I'm underperforming, maybe I could come over here and I could make that perform better by going into my flow part of my equation and without adversely affecting my blood pressure. And if I do that, would I like my resistance to go up, come down, or stay the same? I wouldn't mind if it came down a little bit, or if it certainly did an increase. Whereas if I give dopamine or Levophed or epinephrine, I'll get my flow increase, but I'll pay a price by increasing my afterload. I don't want to do that. If I use a medicine like dobutamine, I've got the benefit of the inotrope, and it may even drop the SVR a little bit. So my index may go up to 2.2, and my SVR may come down to 1400. So in this case, again, using the fact that I have a chance with one drug to have a positive effect on both of these variables, dobutamine looks like a good drug for this case. Now, let me go back through these and talk about something. Nurses are trained, and they're absolute experts at this, and that is pattern recognition. They are unbelievable in being able to recognize patterns. Where it causes problems sometimes is when they get into a situation where the pattern doesn't work. And now you got to go to the next step and figure out now what's going wrong and what do I do next. Now, what patterns do we have on this sheet? Well, patient number 3 is not a sick patient. They're doing fine, so I don't have to worry about that pattern. Patient number 1 is the hypovolemic shock. I've been shot, hit by a car, something like that. That's an easy pattern to recognize. That's the one that comes in the ER. The patient who's in septic shock, That's pretty easy to recognize. Low blood pressure, very, very low SVR, high cardiac output. So that's pretty easy to recognize. The I'm drowning patient, the fulminant permeant edema, that's pretty easy to recognize. They're frothing, I need some fluid off. So what CC nurses are really good at recognizing are the last 4 patients. As it turns out, there's only 2 patients there. There's the I'm drowning, frothy, congestive heart failure patient, that's Lasix. And then there's this other patient. And if you look at this other patient, it turns out this is the same patient at 3 different stages of coming to the ER. And if you look at the first stage is the dopamine patient. Cardiac index is 1.9. SVR hasn't changed much yet, but they dropped their pressure. They come in at that point, we're going to want to put them on dopamine, and we'll fix that. But if they don't come in, and the body's going to start compensating for that, what do? They take their SVR from 1234 to 1500. They compensate by raising their SVR. And when they do that, it stabilizes their blood pressure, right? So blood pressure comes from 70 up to 100, but they pay a price for that. And what price they pay for that? They pay a performance price. It knocks down their performance in their cardiac index from 1.9 to 1.7. If that patient stays there, they're now in a spiral. They've now started this ratcheting, increase SVR, lower cardiac input, increase SVR. If they keep going, they get to the nipride patient. The 2171 index is down to 1.5. And that's really the really bad ventricle, the sick heart that's not fulminant pulmonary edema, but is in the underperformance death spiral. And you'll see that, and CCU nurses are really, really good at recognizing which stage that patient's in. So you'll often get called by a good unit nurse, and they'll say, I think this patient needs some dobutamine, or I think this patient needs some dopamine, or I think we have to put this patient on some nipride. And they're usually pretty good at that. What I'm trying to teach here is to go one step beyond the pattern recognition now. I want you to get to the problem-solving mode, because if usually they're right, you still want to go through the mechanism and figure it out. If they're not right, you have to be able to tell them, no, we're going this way. And you just can't tell them we're going this way, but you need to be able to tell them why. That's how you win the respect of the team, is not just walk in, and if you walk in and say, do it because I'm the doctor, damn it, or do it because I told you so, that doesn't fly. That doesn't give people the reason to do it. If you come in and you say, what I'm really worried about, I think they're in kind of a stage 2 spiral. We've got to get out and really get after this SVR. I know it could drop the pressure, but I think we have enough wedge pressure to deal with that, and so let's go with nitroprusside. If you have an explanation and a rationale, it makes the world of difference. So those are really kind of the stereotypes of cardiac patients that we tend to see over and over and over. And I want you to really kind of be thinking about those when you get into these patterns and see which one you think the patient is. Now, I have a final exam for you. Now that you're experts in hemodynamics, the next question is the following. There's 3 patients on the list. Rank the following patients based on their prognosis, from 1 to 3, with 1 being the worst prognosis. In other words, the patient you select as number 1 is the most likely patient to die. The patient you ranked as number 3 is the least likely patient to die. And I've given you the hemodynamic numbers, but I've changed a few things up on you to see if you can transfer some concepts. I'll give you a few minutes to work on that. Okay, this is designed to really test one last concept that we're going to drive home, and this is really more complicated because I switched some things up on you. Which is the sickest patient? I didn't ask how you're going to treat the patient and what drugs you're going to give them. I said, which is the sickest patient? And everybody, we have a unanimous effect that the ranking is 2, 1, 3. So everybody thinks that the second patient is the sickest, and you're all correct. That is the sickest patient. Then you all thought that the last patient was the healthiest patient. And unfortunately, that's not true. That patient is the healthiest patient. And how did you get tricked into thinking that 1 and 3 were different? And usually the way people get tricked is they look at the cardiac index and they say, well, number 1 has a cardiac index of 1.6 and the other guy has an index of 2.5. And that's a tough one. What we're really looking at is what's the power of the ventricle, not how well regulated the ventricle is. And from that, we're going to have one more formula to deal with. And the formula is left ventricular stroke work index. And there's actually a formula there, left ventricular stroke work index. This is a measure of how much work your left ventricle can do. This is a measure of how much power your heart has. And it's measured on the basis of body surface area. So it's per meter squared. And as it turns out, if you look at these patients, first patient, second patient, and third patient, if you do a stroke volume, what was the patient's stroke volume, by the way? Anybody calculate stroke volumes? You can say you didn't calculate stroke volumes because you didn't give me a cardiac output, so I couldn't do it. But I did give you a cardiac index. And so you could have calculated a stroke volume index, which would tell you the same thing. It would be a different number. It would be about half of the amount of a stroke volume because it's an index, but it tells you exactly the same thing. Had you done a stroke volume index, what you would have found was that these were the numbers. First patient had a stroke volume index of 32. The second patient had a stroke volume index of 17. And the third one had a stroke volume index of 31. So you went ahead and intuitively got the sickest patient because you can tell the second patient has by far the lowest stroke volume. So this is the sickest patient. But how do you tell the difference between this patient and that patient? Turns out stroke volume is not enough to do that. So we go to a formula called left ventricular stroke work index. And when you do that and the calculations on your sheet, it turns out, and by the way, a normal stroke work index is a left ventricular stroke work index is over 45. If your left ventricular stroke work index is less than 20, your prognosis for survival is very, very reduced. You often don't survive if it's less than 20. So when we calculate left ventricular stroke work index, turns out the numbers are 46, 9, and 30. So what this is saying is this patient has substantially more power in their ventricle than this patient. Well, what would be an indication of that if you look at the numbers? Even though I have a depressed cardiac index, look at the blood pressure I'm able to generate. And I'm able to do that at a low heart rate. So one of the reasons his index is down is his heart rate's down, but not that his ventricle is weak. In fact, if you just look at these two people, these ventricles look the same. You take it one more step and you see that there's actually separation. This ventricle actually inherently has more power. The patient's not as well regulated. They're not as in a good a homeostasis state as this patient, but they have more power. And prognostically speaking, that patient's probably in a better category. If you look at the formula for left ventricular stroke work index, after we've gone through all the lectures, this is a very interesting formula. It is equal to stroke volume index times mean arterial pressure minus pulmonary wedge pressure times 0.0136. Let's look at that. There's only three major numbers in there. Let's look at those numbers for a second. What can we learn from those numbers? Well, we have stroke volume. We've talked about how magical that is because it's a ratio. So when we know stroke volume, we really understand there's some relationship between performance, or cardiac output, and heart rate. And we've actually put it as an index, so we have actually even normalized it for body surface area. This is also a measurement of flow, right? We also have mean arterial pressure minus pulmonary wedge pressure. So we have pressure. If we have pressure and we have flow, according to Ohm's law, we probably have some element of resistance in there, don't we? What's this look like? What this mean arterial pressure minus pulmonary wedge pressure? Now that looks familiar. Looks like we're talking about a circuit again, doesn't it? Now this is starting to look like a resistance formula, isn't it? What's our circuit here? Well, that's aorta. So we're going from aorta, and that's left atrium. All the way around the left atrium, that's total vascular resistance. So we're picking up some kind of element of resistance across the pulmonary bed, resistance across the systemic bed, flow, pressure, resistance. Look how much stuff is in there. It's a very, very elegant formula. And when you start to think of the concepts we've been going over for the last few hours, it really starts to say, wow, we learned a lot from this one particular formula. This is something that all of the hemodynamic monitors and all the units spit out. When they do the sheet, it spits the number out. We don't take that number and try to increase it by giving them dobutamine. That's not what it's for. It's just really kind of to tell us how's the patient's prognosis, how are they doing. We're going to manage the patient exactly like we've just practiced for the last hour by looking at their stroke volume, asking the relationship between preload and the performance of stroke volume, and then understanding the relationship with the three variables of Ohm's law. That's how we're going to manage the patient. but it's a nice number to kind of keep in mind and give you a sense for how we're doing. So that was the final exam, and I think in several years we've only had 1 or 2 people get this right. So it's designed to trick you, so we've done that. So hopefully now you got an idea for hemodynamics that will give you a toolkit, and that's all.